Great. Thanks, everybody. Not the most compliant group, but not too bad. For the next 15 minutes, we're going to open it up for public comment. We have 3 speakers. Each will have 5 minutes. Our first is Carl Dangelo from the University of Rochester Medical Center. Carl?
Thank you. I'd like to thank the Institute of Medicine for the opportunity to comment. These comments represent my own opinions and not those of the University of Rochester. And I'll start by saying that I'm evidently, despite the panel's reluctance, I'm evidently foolish enough to take another run at quantifying reasonably foreseeable. I'd also like to acknowledge the importance of listening to the patients that we serve and second the comments that our patient representative just made. As the theologian Eric Law, writing about a very different subject, noted, uncertainty about the future is a basic fact of life. Human beings are bound by linear time. We create rules to ensure that our future will have some kind of order. We perform rituals that will make us feel more certain about our future. These rules and rituals may have started out as genuine efforts to address uncertainties in people's lives. Dr. Law goes on to say that our rituals can become misguided when we allow ourselves to believe that they can ensure a definite future for us. I submit that we need to consider attempts to identify reasonably foreseeable risks in this light. Even our most careful attempts at identifying risk may be wrong from the vantage point of the future that we will then inhabit. With that background, it's worthwhile to consider research-related risks as mapping to several axes, including severity, likelihood, and relationship. Severity obviously can vary from minor to profound. Likelihood encompasses at least 2 questions. First, how likely is a harm to occur? For instance, a particular phenomenon might be particularly well studied, and we might know that there's a 1% risk of that particular harm occurring following a procedure. Second, how confident are we about the magnitude of the risk? For less well-described risks, the 95% confidence interval for the incidence of harm might be quite wide, and in some cases might actually cross 0. The final axis is relationship. How likely is it that the intervention being studied actually causes the observed harm? Evidence can vary from randomized controlled trial meta-analysis evidence to epidemiologic evidence to unsubstantiated belief. Relationship can be particularly difficult to assess if the disease under study can also cause the harm that the proposed interventions could also cause. One potentially reasonable approach to risk would be to categorize them according to a combination of likelihood and relationship. The first category would be known risks. If the likelihood of a harm could be known or estimated, and there is evidence that the harm is related to a study intervention, the risk could be called known. An example of that might be known risk of blood loss that differed between 2 procedures. The known risks, I think, generally would be felt to be reasonably foreseeable. A second and more difficult category would be possible risks. If there is a suspicion that a harm may occur as a result of a research procedure, but the relationship is unclear or poorly substantiated, the risk could be called a possible risk. Risks of uncertain likelihood would also fall into this same category. Possible risk might merit discussion as part of the research consent process in specific circumstances. For instance, if a severe risk was suggested by epidemiological data, but there was no clear evidence of causality. Uncertain harms and benefits that are specific primary outcomes of a research study that the researchers hypothesize will differ between arms has been suggested by OHRP as potentially reasonably foreseeable. Dr. Tyson, in his comments, suggested some additional criteria, including some statistical ones, which might help us to determine which possible risk could be considered reasonably foreseeable. The final category is unexpected risks. Risks that have previously not been described could best be described as unexpected. And as evidently everybody agrees, by definition, these risks cannot be reasonably foreseeable. Finally, although the following comments are more relevant to tomorrow's session, they're crucial in providing a context for discussion concerning research risks. As Dr. Kupperman has pointed out, provision of written information by a researcher does not equal comprehension of risks or any other information by a potential research participant. Any consideration of how consent information is presented needs to take into existing account existing research in areas such as health literacy. Simpler information is often more comprehensible. Less information often leads to more comprehension, and personal contact matters. Second, and finally,
Yes.
Risks and benefits in the two arms of comparative effectiveness research are often the inverse of one another. For instance, the potential benefit in one arm of a study is the risk in another arm of the study, and traditional presentations of risks and benefits may need to be reconsidered in this realm because the traditional way we think about a standard and the difference from that no longer apply. Thank you.
Thank you. Our next public speaker is Jane Otato from Howard University. Don't see her here, so I think we'll move on then to Helen Hunt.
Yes, I'm Helen Hunt from Princeton, New Jersey, and I'm commenting as a patient, and I would like to refer, in the course of my comments, to some publications that are currently out there. Yes, indeed, I have been a patient. You've been asking about a patient's point of view. I have been a patient. Many decades ago, I had bad orthopedic surgery with severe adverse orthopedic effects. And just 12 years ago, by chance, when I was bicycling with a helmet on to protect my head, I was hit from behind very hard by a hit-and-run driver. And I came out of it alive, but I had lots of broken bones, internal bleeding, was in the a #1 trauma care center for 11 days. But I am alive, and I'm very happy to be alive. And no cognitive dysfunction, okay? All right, now about my comments. My comments pertain to issues concerning statins. There are currently, in the recent issue of JAMA Internal Medicine, there are several articles. One is by a patient. The patient was on statins for a long time, and he experienced progressive cognitive, what's the word, not dysfunction, but it begins with I, impairment, cognitive impairment. And because it was cognitive impairment, he was incapable of recognizing what was happening to him. Now, it was only when he forgot to renew his prescription, refill his prescription, or pick it up for several days, and noticed a remarkable cognitive improvement that he became aware of what was going on. Okay, and it's a full-page article, and I hope you all will read it. And he provides some advice. He says, please take your patients' concerns about the risks of statins or other drugs seriously. And of course, there are other risks, which are sometimes downplayed: diabetes, muscle pain, muscle dysfunction, and so forth. But the current articles, there's a very strong editorial by Steve Nissen. There are other articles in there, by a couple of researchers up in the Boston area. There's a recent editorial in Lancet. There have been numerous articles in the British Journal of Medicine. And these are on the subject of, well, the one by Nissen and the two Harvard researchers in JAMA Internal Medicine. This kind of summarizes it all and emphasizes it, that good study strongly suggests that there was a severe overestimation of risk associated with risk factors for cardiovascular diseases or cardiovascular events. And a strong criticism of the use of new unpublished evaluator for assessing or estimating the risk of these risk factors that patients have, with resulting in a greatly increased prescription of statins for people who otherwise would not have them. And this is basically all secret. It's not published. And so it was kept secret from physicians. It was kept secret from patients. So physicians and patients, all of these people, all of us have a cause to distrust the methodology and the lack of transparency. And I'd like to leave you with that.
Okay. Thank you. Okay, that concludes then the public commenting session. Are you?
I'm Tom Obishason from Howard University, and I was wondering whether I can use 2 seconds of Jane Otado's time, since she's also from Howard University and she's not.
No, they're shaking their heads that that's not appropriate. But please, you can raise questions in other times that when there'll be a question and answer period. So apologize for that. So with that, that closes our session on risks. And now I have the pleasure of introducing Rob Calif, who is chairing the next session. So Rob is Professor of Cardiology, Vice Chancellor of Clinical Research at Duke University, and he says he's excited because his panel is going to be showing us a lot of data. So that'll be great.